Hello and welcome to the third mini-lecture in the Neurological Dysfunction series. In this lecture, we will discuss seizure activity. Seizures are episodes of abnormal motor, sensory, autonomic, or psychic activity, or the combination of these, that results from sudden excessive discharge from cerebral neurons. Seizures may involve all or part of the brain, and are often referred to as dysrhythmias of the brain. In this image, I've broken down the different types of seizures and provided a method for differentiating between them. Starting at the top, a partial seizure begins in one area of the brain, whereas a generalized seizure involves both hemispheres. A partial seizure can be simple or complex. In a simple partial seizure, there is no loss of consciousness, the duration is less than 1 minute, and motor symptoms begin in one muscle group and then move. In a complex partial seizure, there is loss of consciousness, and it's usually followed by an aura and automatisms, such as staring, lip smacking, or picking. I added an arrow joining simple, complex, and generalized seizures, because a simple partial seizure can progress into a complex partial seizure, and a complex partial seizure can progress into a generalized seizure. There are 4 types of generalized seizure. Absent seizures were traditionally called petit mal seizures and involve a blank stare. These seizures usually begin and end suddenly. Tonic-clonic seizures, traditionally called grand mal seizures, begin with an aura, which then progresses into alternation between muscle contraction and relaxation. These last an average of 2 to 5 minutes, and there is always a post-ictal state involving confusion or altered mental status. Myoclonic seizures are shock-like spasms. I like to think of these as being similar to the random jerking activity that occurs when you're falling asleep. In fact, the random jerking activity that occurs when you fall asleep is due to a sudden discharge of cerebral neurons. The individual in this case is usually awake, alert, and oriented, and there's usually not any consequences of this form of seizure apart from risk of injury. For instance, if you are carrying something heavy or driving. Atonic seizures are referred to as drop attacks. I like to think of this form of seizure as being struck by lightning. Muscles suddenly tense up and then all relax at once, resulting in a fall. Finally, status epilepticus is a condition in which seizure activity lasts greater than 10 minutes, or there's incomplete recovery from the postictal state before the onset of the next seizure. Status epilepticus is particularly problematic because it imposes a heavy metabolic demand and respiratory irregularity, which can result in cerebral hypoxia or anoxia, resulting in potentially irreversible brain damage. The etiology of seizure activity can be recalled by the mnemonic sick drifter. This includes substrates, isoniazid overdose, cations, eclampsia, drugs, rum, illness, fever, especially in the child, trauma, extra-toxicologic, which includes a variety of drugs, and rat poison. In terms of the assessment, it's important to determine the type, frequency, severity, and precipitating factors associated with the seizure. A thorough history and physical or neurological examination is also warranted. Pay close attention to the patient's medication history. Some labs that may be done include a CBC, BMP, calcium, magnesium, and a tox screen or a urine drug screen. Additionally, an MRI and electroencephalogram are included as part of the workup. Electrodes in an EEG are placed by an individual trained in the appropriate placement. In general, in this image, red refers to the left and blue refers to the right. Common abbreviations seen on an EEG reading include F for frontal lobe, T for temporal lobe, C for central, P for parietal, O for occipital, and Z for midline. This isn't the best quality image, but this is what a typical EEG looks like. You can see the abbreviations displayed on the left of the page and activity associated with that area following each line. There's much more science behind reading these waveforms, but in this case we can at least identify that the patient experienced a myoclonic seizure indicated by the generalized activity that transcends both hemispheres. This EEG is a little cleaner, but lacks the abbreviations on the left side of the page. Regardless, we can see that this individual entered a generalized seizure, likely tonic-clonic in nature. As I mentioned earlier, a seizure is a dysrhythmia of the brain. This essentially looks like ventricular tachycardia of the brain. I've broken down seizure management into time-based phases based on the most current clinical practice guidelines. We will start with the first 5 minutes, referred to as the stabilization phase. In this phase, the priority is to stabilize the patient. Think A, B, C, and D. You'll want to time the seizure from its onset and monitor vital signs frequently. Assess the oxygen saturation and administer oxygen via nasal cannula, titrating to an oxygen saturation greater than 90%. Initiate EKG monitoring or telemetry. Check the patient's blood glucose, and if the glucose is less than 60, then give them 100 milligrams of thiamine, followed by 50 milliliters of D50. Finally, attempt IV access, collect electrolytes, CBC, a tox screen, and anticonvulsant levels. In the 5 to 20 minute range, referred to as the initial therapy phase, one of the following options should be included in management: intravenous lorazepam, diazepam, or midazolam. If the patient's unable to receive one of those options, then IV phenobarbital should be considered, or diazepam per rectal, or midazolam intranasally or buccally. If the seizure continues into the 20 to 40 minute range, then we begin the second therapy phase. In this phase, one of the following should be chosen as a single dose: IV valproic acid, fosphenytoin, or levetiracetam. If none of those options are available, then the patient should receive phenobarbital, if not already given. The following are some additional management principles. Provide for patient privacy. Ease them to the floor if possible. Protect the head with a pad to prevent injury. Loosen any constrictive clothing. If the patient's in bed, remove pillows and raise the side rails. Do not pry the jaws or insert anything into the oral cavity. Do not restrain the patient. And place the patient on their side with the head flexed forward. The following are components that should be included in your documentation of a seizure. Record the circumstances before the seizure. Whether or not there was the occurrence of an aura, the first thing the patient did during the seizure, the type of movements, areas of the body involved, the size of both pupils, and whether or not the eyes were open. Did the head or the eyes turn to one side? Were there any automatisms or incontinence? What was the post-seizure behavior like, cognitively in terms of movement, speech, or sleep? Was there unconsciousness, and what was the duration of it, and the total duration of the seizure? After the seizure, ensure that the patient has a patent airway. Keep the patient on one side to prevent aspiration. Suction the oral cavity as needed. Maintain seizure precautions, which includes the bed in the lowest position, 2 to 3 side rails up and padded. Reorient the patient to the environment, and if there's post-ictal agitation, then use persuasion and gentle restraint to assist the patient in staying calm. Now let's briefly talk about epilepsy. Epilepsy is a group of syndromes characterized by unprovoked recurring seizures. It may be idiopathic or secondary to an underlying condition, for instance, a brain tumor. In addition to the management principles already discussed, these are some additional principles that apply to epilepsy. Prevent head injury, because it's the #1 cause of seizure disorder. Education is key. Prevent injury, as discussed in a prior slide, and educate the patient. In these last few slides, I provided a table that discusses some of the common side effects as well as the toxic effects of various anti epileptic drugs.